Unfortunately, your brain is shrinking. This is a series of MRIs done on someone with active relapsing MS at the baseline year 1, 2, 3, and 4, and you can see by the final MRI, the brain has shrunken. The ventricles or fluid-filled spaces are enlarged due to loss of brain volume, and the sulci, the normal gaps between the gyri, are slightly enlarged. This particular individual had a significant relapse after stopping disease-modifying therapy after year 3, and you can see some new lesions in the left frontal lobe, but atrophy can occur in anyone with MS. And many people think it's a key feature of MS pathology, the loss of central nervous system tissue, and if we can stop it, perhaps we can stop the progression of MS. And I want to look at some facts about atrophy and data on disease-modifying therapies, including hematopoietic stem cell transplant, and how it could prevent atrophy. Though it may be impossible to have no brain shrinkage, as even people in the general population without neurological disease are losing some brain at an atrophy rate of about 0.2 to 0.4% per year, perhaps just normal aging, though people with MS have accelerated brain atrophy at a rate of around 0.5 to up to 1.35% per year, although that's a very high figure. More typical would be less than 1% per year. Atrophy is present immediately at symptom onset. There was a study on people with possible multiple sclerosis, not even a definitive diagnosis, and they had a mean cortical thickness or mean thickness of the surface of the brain of 2.2 millimeters versus 2.48 millimeters in healthy controls. Atrophy accelerates as the disease worsened. People with secondary progressive MS in another study had a mean cortical thickness of 1.98 millimeters, and brain atrophy does correlate with disability, though the correlation is not as strong as you might think. It's about minus 0.391 or minus 0.4, so there is a tendency for people with more brain shrinkage to do worse, but it's not a perfect correlation. Why is that? Well, there's just a lot of individual variability. Some areas of the brain are more important perhaps than others, and of course there's the function of the spinal cord, which is arguably more significant in motor outcomes. But there's definitely a correlation, and in terms of fatigue and cognitive outcomes, I believe it's quite significant. And by the way, there are many neurodegenerative diseases with greater rates of brain atrophy than MS on average. For instance, Alzheimer's disease and progressive supranuclear palsy with rates greater than 1% or even 3% in corticobasal degeneration based on this study. By the way, my name is Brandon Beaber. I make videos about MS every Wednesday, and if you want further sources, please check out the notes below, the references I use to make this video. So what exactly is being lost when the brain is atrophying? Well, these are the brain components. It's largely made of neurons, the cells, the primary functional units of the brain, around 46%, the axons or nerve fibers and their fatty coating, the myelin, is around 24%, and other cells such as glial, supportive cells, immune cells are around 30%. Most of the loss in MS is thought to be related to the neurons, axons, and their coating. There are different hypotheses as to the underlying pathological mechanisms that cause brain shrinkage. Of course, traditional white matter lesions, when immune cells enter the nervous system, enter the perivenular space, damage nervous tissue. This could lead to atrophy. However, many people with MS have clinical progression. They get worse and have brain atrophy even though they don't have relapses and don't develop new lesions, and this may be due to so-called smoldering multiple sclerosis. I have a whole video on this in the notes below, and part of this may be caused by the resident immune cells, the microglia and macrophages within the central nervous system, causing subtle ongoing inflammatory damage. Immune cells can also release iron, which is neurotoxic, and this can cause secondary oxidative stress and loss of neurons. Also, there's evidence even in the normal appearing white matter, which looks normal on conventional MRI, there's ongoing damage to the axons or nerve fibers. This is based on multimodal imaging studies and autopsy studies. There's evidence for a phenomenon called late axonal loss, where maybe you have a relapse or new lesion on MRI, and many years or even decades later, there's slow deterioration of the nerve fibers. This may be caused by dysfunction of the energy-producing organelles within the neurons, the mitochondria. They may not work as well to produce cellular energy after an injury. Also, under certain settings, the excitatory neurotransmitter glutamate can be toxic to the neurons and axons, and also, as mentioned previously, previously, iron being released can generate free radicals such as hydroxyl groups that are created by a chemical reaction called the Fenton reaction, causing injury to the axon years down the line. So I'll get into the data on different disease-modifying therapies and their effects on brain atrophy, but one thing I want to point out is that in an individual, brain atrophy isn't necessarily a great measure. There can be a lot of variation from scan to scan, your hydration and nutrition status, and even certain medications like diuretics can definitely affect brain volume. People with anorexia or ultra-long distance athletes can actually experience temporary brain atrophy that can be reversible. So in an individual person, it doesn't necessarily mean that much. Also, there's this phenomenon of pseudoatrophy. This is a study in people with MS taking the drug Tysabri, and they broke it down into people with active gadolinium-enhancing lesions, the dark gray, and people without active lesions at baseline, the light gray. And so on the left side, you see months 0 to 12, how much atrophy was there in the first year, and on the right side, months 12 to 14. And you can see people who had active lesions have a massive amount of atrophy, minus 1.55%, very significant in the first year. But what's happening here is that they had lesions that were active and swollen, and of course now they're shrinking down and going away, and so it's fooling the computer into thinking that was real brain tissue, where really it was just swelling, and it makes it look like there's a lot of atrophy. This is known as pseudoatrophy, and of course the second year these individuals seem to have less atrophy, and so you have to take this into account. Are you scanning people who had active lesions, and they're going to be these dynamic changes? And so you may need a re-baseline scan after starting an intervention to really know what the rate of atrophy is going forward. So can we slow brain volume loss with our disease-modifying therapies? Luckily, the answer is yes. This is a small meta-analysis of 4 studies on even low-efficacy disease-modifying therapies, and there is an effect. This is the ETOM study on the top. This is interferon beta 1a rebif, and this is actually the lower dose, 22 micrograms. 44 micrograms is the full dose, but there was a statistically significant reduction in brain atrophy. Precise is glatiramer acetate, Copaxone, Glatopa. There was a trend towards less brain atrophy. The Topic study, teriflunomide or Aubagio, at the 14 milligram dose, it didn't seem to do anything, but at the 7 milligram dose, the lower dose, there was some trend towards less atrophy, but when you add it all together, you do a meta-analysis of all these studies, even these weaker medications do reduce atrophy a little bit. So if low efficacy therapies do a little bit, maybe high efficacy therapies are better, and they are. This is data from OPERA 1 and OPERA 2, people with relapsing MS randomized to Ocrevus or Rebif. Ocrevus is a once every 6 month infusion, high in efficacy. Rebif is an injectable beta interferon, lower in efficacy, but did have some effect in reducing brain atrophy in the study I just showed you. And you can see those randomized to Rebif in the red line have more shrinkage than those randomized to Ocrevus. Now the benefit seems to taper off here, and that's because beyond this slash line is the open label extension. So everyone is getting Ocrevus at this point, but the initial randomization to Ocrevus seems to have a sustained benefit. They stayed better the whole way through. People who originally got Rebif had some permanent injury and never caught up. And you may say this looks like a very small difference, and it is, but it's compared, Ocrevus that is, to an agent that already has some effect, and it has a little bit more of an effect. This is the data on Lemtrada. This is actually data from the CARE MS 1 and 2 studies, which were randomized trials, Lemtrada versus Rebif, but we're only looking at the people who got Lemtrada. This is a very potent medication. It depletes both B and T cells. Very strong medication, does have significant risk of infections and secondary autoimmune diseases, but look at this data. You can see in the core study, the randomized portion of the trial, the rates of brain atrophy are significant. Year 1, minus 0.59% or minus 0.48% in CARE MS 2. Okay, that seems like normal MS atrophy, but after that, minus 0.25, 0.19, 0.14, 0.20, 0.17, these are rates of brain atrophy comparable to the general population, just normal aging. So these people have stopped their accelerated brain atrophy due to MS. very impressive. However, the benefit of taking a stronger agent may be more pronounced in younger people who will bring back in REBIF, subcutaneous interferon beta 1a, the black squares, and then of course the blue squares are the data on Lemtrada. You can see if we look at people age 18 to 25, 25 to 35, there's a clear superiority, much less brain atrophy in people getting Lemtrada. But you go to 35 to 45, maybe it's just a little bit, and after age 45, it's not so clear there's any benefit at all, minus 0.45 versus minus 0.5, roughly the same. And this emphasizes the need to stop brain atrophy early, even in young, healthy people with relatively low disability, but potential to get worse later on. Of course, the data aren't always so rosy. This is cladribine or Mavenclad versus placebo, the Clarity trial. If you look at the first 6 months after treatment, the placebo actually does better than cladribine. There's less atrophy. But after the 6-month mark, there seems to be more atrophy with the placebo group, so it's basically a wash at the end of the 2-year study. So maybe there's some therapeutic lag with cladribine, but it could be beneficial in the long run. And the same study did show a correlation between atrophy and greater chance of disability progression. Here is a survival curve of people who are free of disability progression, and the red line is people with the greatest amount of brain atrophy having the greatest chance of progression, and people with the least atrophy, the blue line, having the lowest amount of progression, and those who are in between have a moderate risk of progression, supporting this idea that this is a meaningful outcome measure. Now, what about hematopoietic stem cell transplant? Perhaps the most aggressive therapy would produce the greatest results. I won't go into HSCT for MS in this video. Very briefly, it's not a stem cell therapy, but rather chemotherapy, which wipes out and reboots the immune system, which can sometimes produce long-term remission in MS. Separate video in the notes below if you want to learn more about this topic. This is a study done on secondary progressive MS in Italy on 22 people with SPMS, although they were younger, median age of 37. Generally speaking, people with progressive MS are thought to be not as good candidates for this treatment, but perhaps people who are younger with a lot of active disease will respond. These people did have significant disability with a median EDSS, a measure of disability in MS, of 6.0, meaning the typical person entering this study needed a cane to walk. And they received a regimen called Beam plus ATG. This is a very aggressive conditioning regimen, likely stronger and more effective, in my opinion, than Cytoxan plus ATG. And they had really long follow-up, median follow-up of 99 months. Of course, that's several years. And 12 out of the 22, or 55%, most of them had normalization of brain atrophy, defined as an atrophy rate of under 0.4% per year. You can see the individual data points. They drew this line at minus 0.4%, and certainly many of them did have atrophy rates typical of untreated multiple sclerosis, but a lot of them seem to have normal rates of brain atrophy. Very impressive data when we're talking about progressive MS. This is a graph of the cumulative atrophy of people in the study, and you see an effect similar to with Lemtrada, that maybe atrophy is normal the first year, and then it really plateaus, is very minimal, and then maybe picks up again several years later. Although take this with a grain of salt, because you can see the number of people who followed up to 8 years and beyond really starts to drop off. They divided this into people who were stable, in other words, they were doing well clinically, they didn't have worsening of their symptoms of MS, and people who had progression despite HSCT, and you can see people who were stable were less likely to have brain atrophy or significant brain atrophy. Although again, keep in mind that by the end of the study, there are only 2 people who were actually stable who made it to 8 years and beyond, in other words, followed up with the examiners, because people travel far and wide to get this treatment, and so the sample size here is very small. The data for relapsing MS with HSCT are even better in my opinion. This is another study from Italy looking at people with relapsing remitting MS, again mostly who received Beam plus ATG. There were a few people who received similar but different conditioning regimens, and you can see in year 1, most people, 62%, had rates of brain volume loss greater than 0.4% per year, what they call pathological brain volume loss or accelerated brain atrophy. But by year 2, it was 55% who had normal rates of brain atrophy, and by the last follow-up, it was 75%. So long-term, and of course there could be some biases in who follows up, most people seem to be able to normalize their rate of brain atrophy if they have relapsing MS with Beam plus ATG. Of course, the side effects with this regimen could be very serious, but perhaps it's worth it if you can stop brain volume loss in the long run. So to summarize, brain atrophy is common in MS. It's bad. It's associated with worsening disability. However, we seem to be able to slow it down with disease-modifying therapies, especially with highly effective DMTs, and probably the most proven agents to do this well are Lemtrada and HSCT. Questions for the future: can we do this with less aggressive agents that have lower risk? Are there lifestyle factors that would also reduce brain atrophy? Let me know if you have any comments or questions or suggestions for future videos.